You can see, right?
Yeah.
Okay, so do you want me to start when I'm ready, or are we still
Yes,
waiting? We'll
I
wait a few
think
more minutes.
we have enough participants here, and we can start within a minute. We'll start our session.
Yeah,
So
okay.
before we you start the session, I warm welcome to Aisha from UK, and today's topic is very interesting. And in case we our topic will going to be strengthened long, so we can rejoin our meeting back. So Aisha, you have full time. You can easily talk and just discuss what you want to discuss and what do you want to teach us. So carry on. Thank you.
Okay. So I just wanted to say thank you for inviting me to talk today. As you know, Shinza has said that I'm coming here to talk to you about a new project that we're doing. So I've been a perfusionist in London for over 20 years where I trained. I work in St. Bartholomew's Hospital in London, where we do around 2,000 heart operations every year and around 50 ECMOs. So it's a fairly busy centre. Someone's, I can hear somebody. So I became involved in the London Air Ambulance pre-hospital ECPR project a couple of years ago, and it's nice to be able to share some of the experiences and the journey with you, as I'm sure these projects will continue to increase over the coming years, maybe even in your own countries. Uh, okay. I just need to move this thing to the other side. Okay. So, what I'm going to talk about, these are the objectives of what I'm going to cover in the talk. It's about an introduction to pre-hospital ECPR. I don't know the backgrounds to all of you, but some of you may or may not know what ECPR is or ECMO is, but I guess we have a mixture of participants. So I'll just explain that to you. And around why do we need it? So we look at why we actually need it, what's its important, and what are we trying to achieve by this treatment option. I'll also talk about some global studies that are linked to the project, and they're quite important because it's the evidence behind the projects that different countries have come up with and that we've used a lot to build our own project here in the UK. I'll then specifically talk about the project model, the training program, and different types of challenges, and just conclude by going over the journey so far and the future trajectory and directions of the project. Mm. So I'll start off by talking about the introduction to the pre-hospital ECPR. So ECPR stands for extracorporeal resuscitation, and it is the use of an extracorporeal circuit called ECMO, where we have an external pump and oxygenator used to provide circulatory support to refractory out of hospital cardiac arrest patients. So these are patients that have not responded to conventional advanced life support, CPR, or defibrillation. So they have no ROSC, that is return of spontaneous circulation, after attempting to resuscitate for over 15 minutes. So with pre-hospital ECPR, ECMO is initiated before the patient arrives to the hospital. That's the difference. So this allows oxygen delivery to be reinstated to the body circulation by cannulation of the femoral artery and femoral vein. This is a simple veno-arterial ECMO circuit where blood will drain from the femoral vein, enters into the ECMO machine that oxygenates and pumps the blood back to the patient through the femoral artery. The patient is then rapidly transported to the nearest ECMO heart attack centre for treatment, usually PCI stenting. So the ECPR is essentially used as a bridge to treatment and recovery in these patients. So out-of-hospital ECPR is a time-critical procedure where good outcomes are strongly linked to the amount of time taken to instate ECMO flow. An extended time to ECMO flow over 60 minutes is linked to poorer neurological function. We are essentially aiming for CPC scores of 1 and 2. And in case you don't know, the CPC score is a measurement of neurological outcome in patients. And every minute without effective CPR, survival drops by around 10%. For this type of procedure, selection criteria has to be strict and is formed from a global consensus from studies that show what works and what doesn't. So for the project, the criteria that has been decided is it is suitable for patients less than 40 kilograms, have a witnessed arrest, and have received bystander CPR, and have a shockable rhythm, meaning VT or VF, and that we would be likely to be able to put those patients on ECMO within 60 minutes. So pre-hospital ECPR requires a highly specialized mobile team with specific skill configurations. So we need to be able to have people that have medical personnel skilled in advanced life support and resuscitation, as well as rapid ECMO cannulation and initiation. So the pre-hospital, the specialists, they also require specialist patient management. So we need to have all the people on that team be able to cope with all the different types of things that are presented. So it is a highly specialized team requiring specialist training. I spent some time as part of the project with London Air Ambulance teams to understand the nature of pre-hospital medicine. So I did a few observer shifts, and this made me appreciate how challenging the environments that they are presented with can be. And pre-hospital ECMO absolutely is not the same as in-hospital ECMO. It is definitely more challenging environments with different types of PEP pressures and constraints. So this has to be taken into account when you're thinking about the correct team members with the relevant skills and experience. So this is a high resource service that requires a specialist team skills, specialist equipment, and specialist modes of transport. So this challenges with these types of projects have to be able to demonstrate the cost effectiveness for the hospitals that decide to try them out, essentially. So despite the, so in this slide, we'll look at why do we even need the pre-hospital ECPR, because lots of places don't have that facility anyway. So why is it important? In terms of the London and the UK, and despite the presence of world-class advanced life support and a rapid response, emergency response system, survival from out-of-hospital cardiac arrest is low in London and generally globally. The 2022 England registry data for out-of-hospital cardiac arrest shows a 30-day post-arrest survival of 7.8%. For London, the London Ambulance Service reports a slightly higher 30-day survival rate of 10.8% in London. And global figures are comparable to this. So in London, it's slightly better, perhaps due to a stronger emergency response system and access network, more bystander interventions, and public access to defibrillators. This all makes sense in a densely populated capital city like London, which has a lot of investment. So only 30% of the clinically attended patients in cardiac arrest achieve on-scene ROSC. So 70% of these have refractory cardiac arrest. Most of them die. So this is a particularly large pool of potential patients for ECPR, although specific criteria for the ECPR would narrow this down even further. Pre-hospital ECPR bridges the low flow gap that occurs from the point of the out of hospital arrest and the journey to the hospital cath lab, which usually is greater than 60 minutes, and is why cath lab VA ECPR is largely unsuccessful, or when they do survive, they have relatively poor neurological outcomes. So pre-hospital ECPR not only promises to improve survival rates, but also neurological outcomes in this particular cohort of patients who are lucky enough to survive this experience. Globally, there are a number of established pre-hospital ECPR programs, such as the Netherlands, Australia, and I'll talk more about these on the next slide. So as I said, there are a number of ECPR programs around the world. Most started as feasibility studies, which is essentially a proof of concept check to see whether a proposed intervention is practically achievable and worth scaling up. I've only included the roadside ECPR studies as some of the programs that are out there actually have patients where they take them to the hospital to cannulate. So I haven't included those because they're not comparable to what we're doing in our project. So Paris was the first city to start a true on-scene pre-hospital ECPR study in 2011. This was a prospective study. Data was collected in real time with no randomization, so it was purely observational. Patient outcomes were tracked over 4 years. Data was analyzed for 156 patients, which show a 30-day survival of 29 to 38% with CPC scores of 1 and 2. And you can see that they had rapid cannulation and their response time was as expected in that time frame, 60 to 90 minutes. The arrest trial in Minnesota, that's USA, started in 2020, and this was a randomized control trial. So patients were randomized to either receive ECMO or standard advanced life support. Unusually, this had to be stopped early due to the significant disadvantage those patients were subjected to for not being randomized to receiving ECPR. So that's quite significant. In this study, in the time they did 30 patients, 15 in each category, which gave a 48% versus 7% survival between groups, which again is pretty amazing results. In Melbourne, they did a small prospective real-time study, a feasibility study of only 10 patients, but had similar findings to the other trials with a 30-day survival of around 40% in these patients. And you can see again a very quick cannulation time and response time in that. The biggest ECPR, pre-hospital ECPR trial is the on-scene trial, which is the last one on this table, which was a multi-site nationwide trial in the Netherlands. And data is not currently out yet, but heavily anticipated for next year, the middle of next year. And that will be looking at 3 years of data collected with over 200 patients. So we won't know till next year what that shows, but it is expected to be in line with the results that I've shown here. So now I'll talk specifically about the project in London. This was a project started a few years ago aimed at reducing time from out of hospital cardiac arrest back to full circulatory support. So again, we're trying to improve the survival outcomes in the London area specifically, primarily by bypassing delays in hospital transfer through cannulating on scene rather than in hospital. Also, the project allows us to collect data to assess feasibility, safety, and impact on patient outcomes of the intervention for further expansion and future service models in other areas of the UK to be rolled out if we look at the results and it shows that that's something that would work. So as I said, I've gone through that already, but the actual criteria for the patients that they need to fulfill to receive the intervention, this would be verified at the point of dispatch of the team. We need a witnessed collapse. We need immediate bystander CPR, shockable rhythm, definitely not asystole, and an estimated weight of over 40 kilograms and no visible other significant comorbidities. Sometimes we have to assess that when we get to the scene, but generally the patients are looked at, we're given this list and they decide to dispatch or not. So when you think about it, only a small percentage of patients actually do meet this criteria. Studies show that, other studies show that less than 10%, probably actually more near 5%, of these out-of-hospital cardiac arrests are actually suitable according to this specific inclusion criteria. But on the other hand, these are the patients that evidentially have the best outcomes. So what we have learned is that, yes, the criteria is quite tight, but these are the patients that do the best, and therefore that's what we should focus on according to the evidence that's out there. So patients who meet this criteria will be filtered through the London Ambulance Service call centre, and the ECMO mobile team is on standby and is activated. The team will travel to the patient by car or helicopter, depending on the distance. I would say so far around 50% of the jobs have been helicopter and 50% car. Other further assessments occur on arrival, and if the patient is suitable, they'll be put on ECMO within 60 minutes of arrest. And they are then transferred to one of 4 heart attack centres with ECMO capabilities in the London area for treatment. So this is the team model that we have been using. It consists of 1 HEMS doctor. When I refer to HEMS, I'm talking about helicopter emergency services. So they're specific doctors trained for helicopter emergency medicine. So the team consists of 1 HEMS doctor who cannulates the femoral arteries, and an ECMO doctor who is described as a proctor who oversees the cannulation. So obviously he is an ECMO doctor who has ECMO experience and has been, knows how to cannulate. So he will be present or she will be present to oversee the cannulation. There's a paramedic, so their responsibility is to set up and prime the circuit, and as well as operation of the CardioHelp ECMO device. But I'll just mention that there is a pre-primed ECMO circuit which is taken when dispatched, so that is prepared at base before dispatch and kept for 28, 29 days until it gets used. So as you can see from the model, there is no perfusionist present in this model. Perfusionists are only involved in the training of the team, the ECMO device and the circuit. Normally, a perfusionist would be responsible for setting up and priming the ECMO circuit as well as operation of the ECMO device. But this team model follows international benchmarks where most pre-hospital ECPR programs do not have a perfusionist on their mobile ECMO team. So other consideration to this model include limited helicopter capacity for only 3 personnel plus 2 pilots. Also, we have to consider the nature of pre-hospital medicine is such that the mobile team are pre-hospital medical trained personnel that have specialist training from lots of different specialist professions for the purpose of life-saving roadside care where patients would otherwise normally die. The HEMS doctors are able to do thoracotomies on scene, but they are not cardiothoracic surgeons. So we have to adjust our mindset to understand the context of pre-hospital emergency care is very different from that in hospital. Perfusionists, I don't know about in your countries, but perfusionists are also an extremely limited resource, even in the UK, with around 450 of us. There would not be enough of us to provide staff for these types of additional services and be expected to fulfill our already existing clinical responsibilities in terms of cardiac surgery. So, no. This is the summary of the ECMO competency training framework used to train the non-perfusion ECMO team. So as I said, that would have been the HEMS doctors and the paramedics. The training occurred over 12 months and the project went live earlier this year. The model has been designed and underpinned by a very strong framework of patient safety and governance, which is why it's been rolled out over the year. And it's the first of its kind in the UK, so we kind of have taken our time with establishing it compared to other training programs that are available around the world, which are much shorter and intensive. So the team would meet twice a month for training and simulations or moulages. And as you can see here, the program is divided into 3 phases. Phase 1 was around 3 months and involves developing specific core user-friendly CardioHelp protocols and checklists for setup and priming of the circuit, device hardware, and ECMO management. These were practiced in small group training sessions as well as in high-fidelity group ECPR moulages, which involved timed cannulations and initiation of ECMO using a simulation mannequin. So the phase 2 was about 9 months. Over this period, I wrote a bespoke competency CardioHelp assessment document and a training video for the team. They used this, so this was used to assess team members to say whether they were competent to use the ECMO device without a perfusionist. The competency assessment was an individual 2-hour thorough verbal and practical session for each team member, which, remember, there's 15 of them, so that took quite a long time to go through. And we would also continue simulation training during this period as well. The final phase, which is phase 3, this is the final phase that we're currently in now. This is a service evaluation year, which began in February 2025, where the project went live and is active only 2 days a month for this initial phase. So the team would be on standby for suitable clinical patients. Myself or another perfusionist attends the shift for clinical observation and support of the team evaluating the training that has been received. The team are also supported by an online wider MDT skills group. If that's required, that's also available. And again, we continue ECPR simulations on clinical days where it's quiet and it allows to do so. So these are some pictures from a job that we went on some months ago. You can see here on the left is cannulation of a patient that collapsed outside her house. We can see there that on the left-hand side, they're preparing for cannulation. We have the CardioHelp there, and you see the HEMS doctor cannulating and the proctor by his side, helping him, guiding him, and the patient is receiving advanced life support at the same time. So they're on an automated life support Lucas machine. And you'll see the same patient on the right-hand side in that picture on ECMO and getting ready to be transported. So I could talk about some of the project challenges. So we have had some, challenges with attitudes and perspectives towards the project. And these come from different angles. So I would say a lack of definitive randomized control sort of trial evidence means that many clinicians see pre-hospital ECPR as experimental and therefore low clinical value, making it difficult for people to buy into the concept of it. Concerns also persist about outcomes and the risk of creating survivors with poor CPC scores. There is also cost-benefit skepticism. Some feel the level of investment benefits too few patients compared to other HEMS priorities, such as REBOA or RSI, which are a lot more common requirements than ECPR. Also, deploying expensive intervention to patients with marginal prognosis raises ethical scrutiny as well. And also, why should some areas like London have this available and not others? So that is an equity of access criticism. There are also interdisciplinary politics that have played a part in this kind of project, which you would kind of expect. There have been a number of arising opinions, including should perfusionists, should non-perfusionists be doing perfusionist roles? Are we really able to train them appropriately? How do they maintain their skill sets when the volume of cases performed are quite low? This raised questions within our own perfusion regulatory body. Also, the in-hospital ECMO doctors had similar comments about whether pre-hospital HEMS doctors should be delivering this highly specialized treatment, which they are trained for. But ultimately, it has been decided that based on the reasons that I've already discussed related to international benchmarking, that this team model would be the starting point for the project, with room to adapt if evidence shows that there was need to. However, I would think this model would not be adapted. I think it would be highly unlikely, because if other countries have made this model work and it's demonstrated to be safe, there's no reason why the UK can't. So I doubt that this model will change. Eventually, I think the model is moving towards having just HEMS doctors doing this, so that once the training is complete and sometime later down the line, there may not even be an ECMO doctor present with them. So the logistics, the main logistical issues of the project, some of them have included staffing. So we only have 15 team members that have been trained for this specialist team. And because this is just a feasibility trial, they are doing this project around their existing clinical medical commitments. So it has been quite tricky staffing for the project, and the funding as well. So this is kind of the reason why we only do 2 days a month at this point in time. As I discussed, the team's deployment time, the deployment time for the team is really crucial and is based on the team's activation criteria filtered by London Ambulance Service. So far, this has worked well, as all patients that received ECMO were put on within 60 minutes of arrest, although we are working towards streamlining this further and trying to get this number more close to 45 minutes, maybe less, for greater chances, better outcomes. So transport, again, this has been, the transport aspects of this project has been a well-drilled component of the project, which transport decision about whether it's going to be a helicopter or a car is made based on the location. So generally this has been a 50-50 split, but it has been commented that the helicopter is shared by the HEMS service. So if we use this, we're taking it out of circulation for other emergency patients, and we do have a lot of stabbings and other quite critical emergencies that the HEMS helicopter is frequently used for. So comments can arise around we're using it for something that is quite less frequent. So that's a challenge in a sense. Also, as I said, this is a low volume system. So with a low volume system, we have a team on standby for 8 hours, and suitable patients that meet the criteria are infrequent. So questions come up around having vital staff on standby with not enough work to justify. So cost and sustainability of the project could come into question. Also, maintaining competencies on a low volume system must be adhered to. So again, it means arranging additional training days and competency sessions for team members every 3 months. So it's quite tricky trying to manage that for 15 members of the team. Some of them have not even had the chance to actually have a patient yet. But so we have to kind of keep up with maintaining their competencies. So just to close, as I said, let me just move this. So as I was saying, the role of a perfusionist in this context is in a training capacity. But by doing this, we have ensured that the standards of training have been extremely high, and we have trained these personnel as we would train our own perfusionists. So the quality of training is very high, and that was kind of the compromise we took, and that was the recommendation from the Society of Perfusion of Great Britain and Ireland, that we most definitely had to be heavily involved with the training, devise all the protocols and checklists to make sure that this particular team did meet the standards required, minimum standards of practice, as according to the Society of Perfusion in England. So the journey so far, obviously this is a feasibility study which is underway, so I can't talk too much about it, but we have had, project has been running for 6 months. We've had 3 patients. In that 6 months, we've only put 3 patients on ECMO. And that's how difficult it is when you're just doing 2 days a month and having to capture those already small portion of patients in such a small window of 2 days a month. And in that 2 days a month, we're only operational between 8 and 4 p.m. And we are limited by the HAC centres, the heart attack centres, the ECMO centres, which at this point in time will not take patients after 4 o'clock because it's not part of their practice. So we are limited by that. So in 6 months, we've only put on 3 patients on ECMO. We've had 1 of those patients survive and 2 did not. So that's what the journey looks like so far. But it's mainly being a learning curve, really, learning how to look at each case as they've happened and talk about the things that we can learn and do better from those patients. So we would discuss things like patient selection. Did the patient meet the criteria? Was the dispatch decision correct? Then looking at things like logistics, timings, delays, transport problems, equipment issues, team dynamics, any training gaps, workflow, because everybody on the team has their own roles to play out, and sometimes each individual scene presents different challenges. Like, I think once there was the paramedic was saying that the patient who they were going to put on ECMO, she was not happy that the advanced life support that she was receiving was enough or correct, something along those lines, and she felt obliged to go and help them when actually her role was to operate the cardio help. So when you have things like that, it's where do your loyalties lie? You have to obviously get the patient into a good state before you can put them on ECMO. So sometimes nuances come up on scene that disrupt the workflow that has been simulated and practiced. So simulation is great, but at the end of the day, it doesn't mimic what actually happens on scene in these jobs. And that's why there's a lot to talk about and a lot to learn about from each case. And it's a massive part of learning from each case. So we would have, so this is what the feedback loop is. The feedback loop is after each case, there would be a hot debrief. So the debrief involving the immediate team who are involved in that particular case. And we'll talk about all the things that I just mentioned, but on a very immediate scale. And then at some point down the line, maybe a week, we would talk about the case again with the wider team, maybe the cath lab people who received us, the ambulance team, all the different wider teams that were involved in the case. There would be a wider discussion with those maybe a week later, and then a cold debrief, maybe about a month, where we're again assessing the patient's progress and any changes that we need to be making in terms of training updates, simulations, protocols, refreshers. So we're constantly learning and adapting after each case. And then in the wider scale, we would be looking at sharing knowledge, reporting data, and eventually publishing later on. So the future projections for the project are obviously to get more patients, because only having 3 patients in 6 months, they're a little bit disappointing. Although we have been dispatched to more patients, where sometimes we'll go and attend the patients, they've arrested, and then they put sheaths in. Sometimes they just put a sheath in and just wait and see if the patient's stable or not. Sometimes the patient gets ROSC, so then it's not a candidate for ECMO. So it just depends on refining the things that we're doing on scene. And so once we get more data, I think we may be trying to increase the number of days that the team are available from, maybe rather than 2 days a month to 3 or 4, possibly more. It's going to depend on staffing, but it has been tricky. And we have to be able to demonstrate sustainability. But in the long term, the question is, is this service going to dissolve into being part of the helicopter emergency team? So they will cover these particular patients for ECPR as well as their own cohort, or will we have a separate team for this specifically, which we have to be able to demonstrate the cost effectiveness of that? Because again, we may have teams on standby with trying to capture a very small amount of patients. So overall, it looks like the best model is that it will get dissolved into the usual HEMS shifts that the HEMS doctors would do. And that's probably what would work long term. But those are things that will come out in the next few months as part of the ongoing discussions and seeing how the project develops further. But yeah, so that's kind of all I'm going to say about it for now. I hope that it wasn't too long. Gosh, it was that 40 minutes. But thanks for listening anyway. So let me stop sharing.
Thank you so much, Aisha. It was really very informative. We learned a lot. Great experience with a great project. You are hearing me?
Yes, I can hear you.
Yeah, okay. So I'm going to open the forum for questions, and I will ask you the later question. Before, I just want to see in our group, anyone have any question, please? Then I'll be the second.
You
So
can ask me about this or anything else.
yeah, so Aisha, I have a question for you. As your project is mind blowing, very good, but unfortunately, without the perfusionist, great. You are teaching, you are doing a great like a mentorship for the doctors, for the nurses, allied health professionals, and as what I notice in your project that you eliminate the perfusionist, right?
Yeah, that's
And
right. Yeah.
secondly, your project, you used only the cardio help. Do you have experience to use any other console during your transportations, like by air transportation of your ECMO patients? Have you experienced with other console or just with the cardio?
So at the hospital that I work at, we have two systems. We have the CardioHelp, which is for um, like out of hospital retrievals, which we do, and we have a CenturyMag Chalice system, which we use for in-house ECMO. Now, in terms of transportability of both those systems, I've used both, and the Chalice system, the CenturyMag system, I don't know whether you're aware, you
Yeah,
know
yeah,
of.
we are
Yeah,
using.
it's not it's not anywhere near as nice to use as a transport
Yeah,
model because you have to take a backup console, you have to use two of them,
yeah, we
and
experience with this is a difficulty.
yeah, it's not
The
ideal. The
backup and
Cardio
then
Help is was designed for portability and for that purpose. So um, that is always going to be the choice of anything that is going to be transported through ambulance or air. But I'm aware of lots of other types of consoles coming onto the market now that are actually very good competitors for the Cardio Help. I know Spectrum have a very nice portable ECMO device, which is even smaller than the Cardio Help. And so, the team, if it when it expands, may end up looking at that because portability is the main thing about this. It has to be portable for us, the ease of use, portability. The cardio help, I think, is, you know, like 10 kilos. And the amount of equipment that we take out on these jobs it's a lot. So we take a primed circuit, a primed cardio help must, you know, weigh, over 11, 12 kilos plus all the other stuff that we take out as well. It's quite a lot of stuff. So it's really important to try and minimize the amount of weight that these guys have to carry with them.
usually we are using like for the pediatric we use a Xenius, and for the adult we use a cardio health for the transportation, and even in the time of the COVID we use the even the Centromag. Of course, Centromag we are using in house is not ideally for transportation. Even
No.
the Xenius is not ideal for the transportation. For the pediatric surgery, yes. My
Mm,
second question is, how about the cannulations and the logistics?
mm,
So, what is the ideal cannulations? As you know, in a ECPR, it is difficult to cannulate, especially with the
mm.
situation where the patient is arrested and you're using the Lucas where the for to give a compressions, and what is the
Yeah.
ideal cannulations you are going to be as in your routine in this your project, the size of your access and the return cannula. And what
Mm.
about the second question, and how about the your distal cannulations? As I know, there's a time frame is like a 6 hour. You can cannulate within a 6 hour. How about that? Sorry for
So
long question.
they take, yeah, they take standard cannulas. They only take two, like one size, which will be a drainage 25 French and a return cannula of 17. And that's standard.
Yeah.
And they don't take a choice of cannulas. Those are the ones that we take. And to be fair, they have worked fine. In terms of the distal cannulas, they don't do the distal cannulas on the scene. That's something that we can add later on. Um, from what I've seen, that's not part of the protocol, but it will be added once we get to the ECMO center. And once you get to the ECMO center, I mean, this, if you think about it, this is just literally to to reestablish circulation, and it's not really to refine the kind of to make it perfect. We just want to get them onto ECMO, get them into ambulance, and get them to the nearest ECMO center. There we can address things like if there's drainage problems, and we can add cannulas, and the ECMO center would separately deal with that. So we hand over to them in the cath lab, and then we will hand over to the perfusion team at the cath lab at that particular hospital, and then they will take over management of the patient. And these HEMS guys, they go once they've handed the patient over, they don't stay any time further. Once we transfer them onto the ECMO center's own ECMO system, they leave the building. And yes, cannulation is really tricky because the patients are on the Lucas receiving, automated CPR, which is difficult because the patient is moving about and you're trying to cannulate. So, but this is part of the simulation, which is why it has been like, simulated time and time again, over and over again. These guys are quite, are pretty slick at it. Most of the cannulations that I've seen are, occurring about 15 minutes, within 15 minutes. So they're trained to do that, and that's the difference.
From my side, the last question, because for the rest of the people can ask the question. The last, as we are running here, the ECMO Paris courses here in Doha, Qatar. Your presentation is marvelous, mind-blowing, very well
Oh, thank you.
concise, and it's a really very fantastic. But my only one concern is related, as you run the project without the perfusion, especially in the
Mm.
pre-hospitals and outside the hospitals. Do you get any difficulties in the initial phases, like the project? That without perfusionist, the managing, like nowadays we in medical intensive care as a perfusionist, we just go only for the initiation and only for the transportation. The rest of the part is done by the nurses, especially ECMO
Mm.
nurses, specialists.
Mm.
But
Yeah.
even for our international transportations, we used to do the international transportation here. So we always prefer one perfusionist, one intensivist, and one the CCP, and one ECMO doctor, like a four of the group. So we didn't eliminate a perfusionist from the group. So how was the experience without the perfusionist, especially in the term of the transportations and the in an aeroplane, in an aircraft, you have very specific, very limited place where you're not able to fix it properly. So you
Mm.
need someone who's a very well trained, experienced person to manage the console and the circuit. This is
Yeah. They have so they have an ECMO doctor. So the ECMO consultant is obviously trained in managing the circuit, and they manage because obviously at the hospital when we put someone on ECMO, like you just said, we would be responsible for, getting them onto ECMO and transferring them to the unit where then the nurses and the doctors, the ECMO doctors look after them. So there is an ECMO doctor on the team, and they have trained. So all the members of the team have done extensive training. As I said, I trained when I wrote the competency document. It was pretty comprehensive. It's a 2 hour, one-to-one assessment of them priming the circuit, dealing with managing the ECMO. So it covered all the aspects of managing the ECMO. And I agree that, okay, you can say that somebody's trained and they can do it, but when problems happen, and that's the time when you do need experienced people to help manage the circuit. But unfortunately, this has been, like I said, the other international models have demonstrated they've already set the standard that a perfusionist is not required, and that other medical professionals can be trained to manage the circuit, to manage the hardware. It is something that, can be taught. And, like I said, there's not enough of us to be able to do that. If they want to then decide that they want to have a specific team of just a perfusionist, an ECMO doctor, and a HEMS doctor that are going to go and do these patients, then we would probably have to have more perfusionists, you know. So it's something that we have to think about. It's not like this is the reason why we do feasibility studies to see what works and what doesn't. At the moment, this model is reflecting the international models that I spoke about in the Netherlands, in Paris, in Australia. They do not have perfusionists on their mobile ECMO teams. And the thing is, perfusionists are not pre-hospital trained. And I didn't fully appreciate how difficult that was, how difficult it was because I went with them. I spent some time with London Ambulance and the ambulance service attending the type of jobs that they attend. And I was really blown away by how difficult the scenes that they work on are, and how a perfusionist doesn't have that knowledge, doesn't have that training, and you know, and it's about multitasking because the paramedic, they can not only just be trained to operate the cardio help, but they're also trained in other aspects of pre-hospital medicine. They help out, they've got other roles. They're not just doing the cardio help, they're not just setting up and priming, they're not just focused on the ECMO, they're actually doing other things within their workflow. So it's about multitasking. A lot of pre-hospital medicine is about multitasking. It's not about one person doing one job and sticking in their little corner. It's about everyone getting together and trying to save this life of this patient on the roadside that will otherwise die. So it's a different mindset. So yeah, a lot of perfusionists do say, well, I don't agree with this. Perfusionists should be doing this. But I've seen the other side of that, working with these teams and seeing the kind of things that they develop and the conditions that they work with. It's quite difficult. So I can see both sides of the argument, but at the end of the day, if other countries have this model and this is what they're doing, then it's more than likely that everybody else is going to do that if they can show it's safe and it works. So that's unfortunately how it looks like it might go.
Thank you. Thank you for justifications. Question from the group. If there is no question, then we're going to wind up with the big thanks
No
for your
problem.
precious time. So this is some from Salman Bhattu. Sorry, I got a but excellent. Okay, so maybe he left. I think so. So thank you so much, Aisha. We are looking forward to see you again with some interesting topic. Have a nice and very good day. Take care.
Yeah, and you. Thanks again for having me, and I hope you all found it interesting.
Very interesting. Thanks a lot. Thank
All
you.
right,
Bye. Bye.
take
Bye.
care.
Bye.
All
Bye.
right,
Take care.
bye-bye. Bye.